up the questions towards the end of the session. So we can go ahead with the second speaker.
Very dear Dr. Vivek Gupta, who shall be deliberating on CABG with or without bypass, and he is a renowned faculty consultant in Department of Cardiac Anesthesia and Intensive Care and coordinator of ECMO program. His areas of interest are ECMO in toxicology, basic and advanced CPR training, RRT in ICUs, quality in healthcare, infection control in ICU, advanced hemodynamic monitoring, including PE. Has got numerous publications to his credit in national and international journals, and he is chairman of the Research and Ethics Committee, vice president of ECMO Society, past secretary of ECMO Society, and so forth. Lots and lots of credits to him. Even avoided FACTA also, section editor of JOCP, API textbook 2016, and editor of Anesthesia Update 2016. I invite Dr. Vivek Gupta to deliberate on off-pump or on-pump CABG. Dr. Vivek Gupta, please.
Good morning, all. First of all, thanks to organizer for giving this opportunity to me. I'll be speaking on anesthetic management in CABG patients, both on-pump means use of cardiopulmonary bypass, or off-pump means on the beating heart. Off-pump CABG is not actually a recent invention. Before the cardiopulmonary bypass, off-pump CABG was performed for coronary revascularization, but because of the advancement with the cardiopulmonary bypass and cardioplegia technique, this technique was not used regularly. But in the early 80s, it was found that this can be useful in certain high-risk category of the patient to prevent the neurological complications or the renal complications, and it was again started. Quickly, we'll have a look on the coronary artery, the coronary circulation. Two arteries, left main coronary artery divides into left circumflex and left anterior descending, which reaches up to the apex of the heart, and right coronary artery, which gives the posterior descending artery and reaches up to the crux of the heart. So let's start with a case of 56-year-old patient who had a chest pain for the last 15 days, especially while walking and retreats with the rest. He also had the breathlessness, though he was stable hemodynamically. He's a known diabetic and hypertensive. After initial stabilization, a coronary angiography was done and it was found to have a triple vessel disease. So he was planned for CABG and a pre-anesthetic assessment was sought from us. So quickly, how this myocardial ischemia takes place. It is basically imbalance between the oxygen delivery and the oxygen demand. When the delivery decreases, the condition where there is a decreased coronary blood flow or decreased arterial oxygen content due to anemia or hypoxemia, or if there is decreased oxygen extraction, or when there is an increased oxygen demand because of tachycardia, increasing wall stress, or increasing cardiac contractility. So if there is an imbalance, this will lead to myocardial ischemia and patient will have the anginal pain or ECG changes. So basically, what are our goals as an anesthesiologist? We must provide a safe anesthesia with using a technique which offers the maximum myocardial protection and hemodynamic stability. We try to stabilize hemodynamically throughout the procedure by using a physical and pharmacological method. We allow an early emergence, fast-track extubation, and we ensure that we are giving adequate analgesia in the post-operative period. So a pre-operative assessment will guide us about the risk stratification so that we can explain the perioperative, intraoperative, and post-operative risk to the patient. So a thorough history, we should include the review of the paper as well as confirming the history from the patient, and we can take further history depending upon the comorbidities. The history should focus on the primary problem, progression of the disease, as well as the comorbidities. Our examination should be focused on the general examination, airway assistant, and systemic examination, and we should review all relevant investigations for that patient depending upon the comorbidities. So a history, where angina is stable or unstable. What is the grade of dyspnea? Is there a history of any recent myocardial infarction? Patient is having episodes of cardiac failure, or there is a flash pulmonary edema in the recent period. While evaluating, we should look for any edema, tachycardia, hypo or hypertension, raised JVP, and presence of any marker suggestive of any mechanical issues like mitral regurgitation or a ventricular fracture. It is important to look for a recent or rapid progression of the symptoms severity, particularly the onset of angina. We should alert an anesthesiologist that this patient may have the perioperative ventricular dysfunction. We should assess the activity status by looking at the METs. So if the MET is above 7, it means it's good. But if it is less than 4, it means it's poor. We can look at the various grades of angina, grade 1 from the no angina on the ordinary physical activity to increasing trend to a grade 4 where patient is unable to carry out any physical activity without discomfort. Similarly, heart failure, class A NYHA class 1, where no limitation of the physical activity with all the ordinary activity, and class 4, where patient is unable to carry out any physical activity without discomfort. So we look at the X-rays that will guide us the cardiomegaly, any pericardial effusion, parenchymal, lung parenchymal changes, and about the aorta that there is no calcification. We look at ECG, we compare with the previous ECG, we look at the territory of the infarct, whether it's anterior, inferior, or anteroseptal. Any recent infarct or there's a development of the Q wave, any conduction abnormality or atrial fibrillation. 2D echocardiography will guide us about the LV functions, about the hypokinesia or akinesia, or any valvular lesions, or any other concomitant disease. Coronary angiography will talk about number and site and severity of the disease, whether it's a left main or left main equivalent, such as ostial, left anterior descending, or right coronary artery disease. To evaluate the respiratory system of the patient, take any history of the recent respiratory tract infection, smoking, asthma, or COPD. Is the patient is having a shortness of breath at rest? There are crepitation or bronchi. Look at the X-ray. If the patient is a chronic smoker or COPD, look at the blood gases. And lung function test is required if we suspect a severe obstructive or restrictive lung disease, but one should be careful for a patient who is having angina. Evaluate renal functions. If patient is having a uncontrolled diabetes or hypertension, any nephrotoxic drug patient is taking, or patient has undergone any surgery, or patient is on regular dialysis. Look at the serum electrolyte, especially the potassium, serum creatinine and blood urea, and if needed, do an ultrasound abdomen to evaluate the renal function. GI tract history and evaluation to look for the gastroesophageal reflux disease and peptic ulcer disease. This will help to reduce the risk of regurgitation, and we can see for any contraindications such as mediastinal radiation esophageal structure for the placement of the transesophageal echocardiography. Look at the liver enzyme clotting profile and serum protein. Patient should be assessed neurologically for any history of CVA or syncopal attack, which syncopal attack can be suggestive of even complete heart block. Evaluate for any residual weakness if he had the cerebral accident, or any sensory loss or carotid view. And if needed, patient may undergo CT or MRI, but carotid Doppler to rule out any atherosclerotic changes in the carotid artery. Assess the diabetic status, for how long the patient is having diabetes, what treatment he is taking, and how good is that control is. And always look for the complications such as neuropathy, nephropathy, and retinopathy. If the patient is having underlying thyroid disease, look for the thyroid status, any surgery patient has undergone for the thyroid, what current treatment patient is taking, and what is the present TSH and functional T4 status. Look for the other allergy, especially the allergy with the seafood, because patient can have the protomin reaction. Current medication, all anti-anginal, antihypertensive, antiarrhythmic, and anti-diabetic drugs. But remember, we should avoid any ACE inhibitors for these patients. Assess for the patient cooperation that will help you to insert the line on the day of surgery and do a thorough airway assessment. There are certain investigations which must be performed routinely for all patients, and certain investigations which are specific for certain patients who are having underlying pathology or certain history. So a blood count, coagulation studies, blood group determination, electrolyte, renal functions, hepatic functions, 12-lead ECG, and the angiography report is mandatory, is a routine preoperative investigation for almost all patients. So a coronary angiography and echocardiography should be seen thoroughly by an anesthesiologist. By doing this, sorry, we can have assess the risk of post-operative morbidity as well as the post-operative mortality. In the cardiac surgical procedures, we follow certain scoring system, though it is not important for the anesthesiologist to evaluate these scoring system, but it is done by the surgeon, and anesthetist should have a thorough knowledge of these scoring systems. So the communication to the patients or patient relative will be similar. So there are multiple variables, different scoring system, like a commonly used personal system or Euroscore 2. They take the various factors like age, female gender, cardiac functions, what is the type of surgery, how urgent is the surgery. The commonly used is the Euroscore 2 now. However, certain hospitals use the personality score as well, which ranges from 0 to 4 scoring. Risk of death is less than 1%, and if the score goes beyond 20, the chances of mortality is as high as 30%. The Euroscore 2 also uses several factors, several parameters, variables, and accordingly, the risk calculation for the morbidity and mortality can be done. Whatever the risk stratification method is being used, the most common factors which are associated with the higher risk is the age above 80, decompensated heart failure, cardiogenic shock, or acute kidney injury patients. Factor with the moderate risk are age above 70, reduced surgery, emergency surgery, patient is having pulmonary hypertension, or a patient is a case of chronic kidney disease. The other factor which increases the risk include the diabetes, hypertension, obesity, ejection fraction less than 40%, patient is having a simultaneous valve surgery, or there is aneurysm, or a female patient. So how to pre-medicate these patients? The focus should be on the reducing the fear and anxiety and making a patient comfortable. So we can use the sedation, diazepam or clonazepam, night prior to surgery and the day of surgery in the morning hours. However, we can give the midazolam intravenously on the day of surgery, 1 to 2 milligram, to make patient comfortable and as an anxiolysis. Patient must receive all his anti-anginal, antiarrhythmic, and antihypertensive except the ACE inhibitors. Oral hypoglycemic and insulin should not be administered, but during the intraoperative period, an insulin infusion should be started depending upon how much is the blood sugar level. Once the patient has arrived to the operation room, patient may receive more anxiolytics if needed, if patient is anxious, before doing the cannulation. And the temperature and other ambience in the operation room should be comfortable to the patient. As an analgesic, we can use the morphine intramuscularly 0.1 to 0.15 mg per kg, or we can use the fentanyl 50 to 70 microgram intravenously. How we manage the anesthesia during the CABG? Once the patient has arrived, we should ensure that we are giving oxygen to the patient. We attach the ECG, pulse oximeter, and non-invasive blood pressure. We can do a cannulation of the radial artery with the help of under local anesthesia, and we can send an APPEC sample and we can initiate a continuous arterial blood pressure monitoring. We can place the central venous catheter or pulmonary artery catheter in a high-risk patient before induction of anesthesia itself under local anesthesia if the patient is cooperative. Most important monitoring is the ECG monitoring. The electrode should be placed on the back of the patient. We should focus with the lead 2 and lead 5 and ensure that you are getting an adequate ECG trace on the monitor throughout the surgery, and especially you are able to identify the P wave and the QRS complex, because while manipulating the heart during the grafting, there will be change in the ECG shape. And whenever you are doing a ECG monitoring, ensure that there is a ST segment monitoring is in progress. So any change in the trend of the ST segment, you can quickly identify. Here you can see on the upper ECG, there is some subendocardial ischemia in the form of ST depression. while there is a transpleural ischemia in the form of ST elevation. Arterial blood pressure monitoring with the use of radial artery, it will give a continuous beat to beat arterial blood pressure monitoring and it will give us a good guide. But before placing the radial artery cannula, we should ensure that the ulnar collateral circulation on that particular arm is adequate by using the modified LN test. It should be used usually in the non-dominant side, but if the surgeon is taking out the left radial artery, then it should be placed on the right radial. There can always be difference in the post-cardiopulmonary bypass period in the radial artery and the femoral artery pressure. So a femoral artery cannulation in the CABG patient must be done, which can be helpful for placing an intra-aortic balloon in case of patient is not recovering, and a continuous arterial blood pressure monitoring while rewarming. Central venous cannulation is needed because good amount of fluid is required and patient requires a multiple drug infusion as well. It will help us to give a guide for the filling pressures, though it is not a very good surrogate for left atrial pressure, but still by looking at trend, we can understand the filling pressures. But we should remember while placing the central venous catheter before the induction, and we have already given the sedation to the patient, we should give a supplemental oxygen to avoid any hypoxia prior to induction of the patient. Multiluminal catheter will help us to administer fluid and drug infusion simultaneously. The pulmonary artery catheter should be kept only for those patients who are having impaired ventricular functions. Our patient is having a high risk of intraoperative ischemia. Our patient is having a severe comorbid conditions, or we are going to perform the 2 or 3 procedures together. For example, CABG with mitral valve replacement, or CABG with the carotid endarterectomy, etc. Because pulmonary artery catheter will guide us about the pulmonary capillary wedge pressure, diastolic pressure as a surrogate for the filling pressure. Transesophageal echocardiography, this is another tool to give a good guide in the intraoperative period for the ventricular preload contractility, or identifying the myocardial ischemia, and several other things such as aortic cannulation site, or even the valve pathology, and identifying any defect like a ventricular septal defect or atrial septal defect can be identified in the intraoperative period. So it can help us to identify very quickly the myocardial ischemia, and if there is a segmental wall motion abnormality, even before the ECG changes, we can quickly identify with the help of transesophageal echocardiography. We use usually the short axis mid-papillary muscle view to look for any regional wall motion abnormality. And it can be helpful in those patients, especially when there is a bundle branch block or extensive Q wave or STT changes, where it is difficult to identify any ischemia. The TE will be a good guide to identify it. How do we manage the anesthesia during CABG? A baseline arterial blood gas before intubation or induction of anesthesia. Then we induce anesthesia and ensure that we have placed the proper endotracheal tube. We ensure a baseline activated clotting time, which is usually 80 to 120 seconds, which will help us to guide about the heparin doses. Police catheter for urine output assessment, temperature monitoring, both for the core temperature with the use of bladder esophageal and nasopharyngeal temperature, which will guide us for the brain temperature. The cerebral monitoring can be done with the use of bispectral index or using of the entropy or PSI ray. Whatever method we are using, this will guide us to ensure the adequate depth of anesthesia. How do we induce the patient? It is important to understand that while inducing the patient, there is a risk of hemodynamic instability, especially when there is a patient's cardiac functions is not good. So a titrated dose of the drug induction agent should be administered irrespective of the type of the induction agent. While inducing, we should avoid both hypertension and tachycardia or hypotension and bradycardia. Both can be detrimental because both will make an imbalance between the oxygen supply and demand. There is no single strategy for all cardiac surgical patients. We can use hypnotics, opioids, volatile anesthetic agent, or combination of the both for induction and maintenance of anesthesia. The commonly used drug for the induction of anesthesia can be thiopentone, propofol, or etomidate. So a thiopentone, we can use the hypnotic dose ranging from 50 to 125 milligram. Because it leads to a decrease in the cardiac output, stroke volume, and systemic vascular resistance. And the decrease in the marker contractility also can take place. We should always remember that it can increase the airway resistance, it can precipitate the bronchospasm, and it may lead to post-operative nausea and vomiting, more risk as compared to the propofol. The other drug induction agent, which is very commonly used, is the propofol. The induction dose is 1.5 to 2.5 milligram per kilogram of body weight, but should be reduced 25 to 50% in cases of elderly patients. But propofol also reduces the systemic blood pressure, decreases the cardiac output, and systemic vascular resistance. So we should be careful that there can be risk of hemodynamic instability. The most cardiostable drug is the etomidate. It can be used in the dose of 0.2 to 0.4 milligram per kilogram of body weight. It is an ideal drug for the rapid induction of anesthesia in the patient with ischemic heart disease. But the limiting factor is the depression of the adenocortical, depression of the adenocortical function if the drug is being in the repeated doses. Ketamine, it is not a good choice for induction of the anesthesia in the patients with the coronary artery disease because it increases the heart rate, increases the cardiac output and blood pressure, so that it increases the marker oxygen requirement. The other drugs which are commonly used is the benzodiazepines. The most commonly used drug is the midazolam, which is used as an induction agent from the dose of 0.12 to 0.2 milligram per kilogram of body weight over 30 to 60 seconds. But it leads to a slower induction because it has a slower onset of action as compared to the other induction agent, and it takes longer time for awakening from the anesthesia. All neuromuscular blocking agents has been used for the cardiac surgical patients. Longer acting agents can be used for a patient where we are not extubating patients early, we are not doing the fast tracking. So pancuronium can be a good choice because it has an additional advantage of offsetting the bradycardia because of high dose of opioids. However, the rocuronium is a most hemodynamically stable neuromuscular blocking agent, and it can help for the fast track anesthesia as well. We can maintain the anesthesia with the use of intravenous anesthetic agent. We avoid any high dose of opioids or long-acting drugs so that the patient can recover from anesthesia quickly. So shorter acting drug in the form of propofol infusion, remifentanil or sulopenem infusion can be used, or even a combination of low-dose midazolam with the opioids can be used. Volatile anesthetic agent, it basically decreases both oxygen supply as well as the demand. They decreases the afterload and the systemic vascular resistance, and they decreases the contractility as well. They can have the protective effect because of preconditioning. However, there's a risk of coronary steel, especially the with the use of isoflurane. However, how much it is clinically significant, it is difficult to say. If we have planned for the on-pump CABG, means with the use of cardiopulmonary bypass, we should, as an anesthesiologist, we should ensure that we are maintaining adequate hemodynamics prior to going on bypass, so ensuring adequate brain and kidney perfusion. Especially when the surgeon is manipulating the heart, there is always a risk of reduction in the blood pressure, which can be detrimental. So the hemodynamics should be maintained with the help of volumes, resuscitation, Trendelenburg position, as well as with the use of a small dose of phenylephrine for increasing the blood pressure. How do we manage when we are planning to going on bypass? Make sure that the adequate heparinization has been done and ACT is above 400. While surgeon is doing the venous cannulation, make sure that there is no arrhythmia. When they are doing the aortic cannulation, bring down the systemic blood pressure around 90 to 100 millimeter of systolic blood pressure, because there is a risk of aortic dissection, or there can be risk of emboli because of clot or air. So one should be careful while surgeon is cannulating. Once adequate heparinization has taken place, CPB can be started and the pump flow can be gradually increased to 2 to 2.5 liter per minute per meter square. Once surgeon is ready and has done the cross clamp, they can administer the cardioplegia to stop heart completely, and we can stop ventilation once the full flow has been achieved from the perfusionist side. We try to maintain the mean arterial pressure around 50 to 80 millimeter of mercury, so to ensure the adequate organ perfusion. Because there is a hemodilution with the use of priming solution that we use as a crystalloid, so we try to maintain a hematocrit between 20 to 25, and always add the sedatives, analgesic as well as the muscle relaxant, anesthetic drugs on the cardiopulmonary bypass, because the drugs are getting diluted because of the priming solution. Intraoperatively, make sure blood gas analysis is being done every half hourly. We are looking at the blood glucose levels, serum potassium levels, and ACT is also done every half hourly. And on cardiopulmonary bypass, the ACT is maintained around 400 to 500. TEG is not done routinely, but if you are expecting coagulation abnormality and bleeding risk, baseline TEG should always be done to compare for the future thromboelastoma. Once the revascularization is complete and the rewarming has been done, the weaning from the cardiopulmonary bypass should be initiated. But as an anesthesiologist, one should be ready with the inotropes or vasopressors, whatever you are choosing for that particular case. Atrial and ventricular pacing on the epicardial lead may be required in the patient, especially if the patient is having the AV block or bradycardia. And once the sinus rhythm has recovered, because this will give a best cardiac output, so we should always maintain a sinus rhythm. If the patient is not responding with the epinephrine, dopamine, or dobutamine, and cardiac index is not improving, then patient may require intra-aortic balloon pump in the intraoperative period. Once we have come off bypass and patient is hemodynamically stable, we reverse the heparin with the protamine in the ratio of 1:1, but the protamine should be given slowly because there is a risk of reaction. Once the adequate hemostasis has been achieved, the chest closure should be done and patient should be transported to the recovery area. Transesophageal echocardiography probe should be removed, stomach should be decompressed, and patient continuous monitoring should be done of the ECG blood pressure and SpO2 while transporting the patient. While transporting, one should be careful that the chest tube is under water seal so that there is no pneumothorax and the mediastinal tube is not clamped. Otherwise, there is always a risk of tamper. If we have chosen the off-pump CABG, it has certain advantage over the on-pump CABG. Here, there's a less risk of systemic inflammatory response because we are not using a cardiopulmonary bypass. It's a foreign circuit and oxygenator. There's a less risk of coagulopathy because hypothermia, we are avoiding hypothermia as well as we are using a less heparin as compared to the on-pump CABG. There's a less risk of neurological dysfunctions or renal dysfunction, less ICU stay as well as better survival, less myocardial injury, and less requirement of the transfusion. So it is beneficial in the high-risk patient, especially the patient with the neurological disease or patient with the renal disease. But there are certain conditions if the patient is having an intracavitary thrombus, or there is a malignant ventricular arrhythmia, or there is a deeper intramyocardial muscle, or we are planning for the combined procedure, then off-pump CABG should not be performed. So what are the goals? Goal remains the same in the off-pump CABG as well. We provide a safe anesthesia, we maintain the hemodynamics, we allow an early emergence, and we ensure adequate pain relief. What strategy should be followed during the off-pump CABG? We should use a shorter acting induction agent. We reduce the dose of opioids, but ensure adequate analgesia. So we use a shorter acting opioids. Administration of opioid should be done in terms of infusion, and we maintain with the combination of inhalation agent and the propofol. Intensive monitoring and maintenance of hemodynamics throughout the procedure, so we can do an early extubation and a good pain relief with the help of thoracic epidural or the intrathecal opioid should be done for an early extubation. Anesthetic approach, here we can use the general anesthesia with the opioids and inhalation agents, or we can combine the general anesthesia with the thoracic epidural or intrathecal morphine, or even we can do an awake regional anesthesia with the use of thoracic epidural anesthesia alone. problems with the off-pump CABG, surgeon usually faces two problems. Because when they are doing an anastomosis, so they may have a difficulty of adequate exposure because of the cardiac motion. And second, there is a risk of myocardial ischemia during the when they are doing a grafting. There is a flow interruption. For this purpose, how we can help them? We must be prepared for any severe hemodynamic alteration, or transient deterioration in the cardiac pump function, or acute intraoperative myocardial ischemia. So hemodynamic management is very, very important during this time while they are positioning, and there should be good communication between the surgeon and anesthesiologist. And anytime the patient has deteriorated, there's a ventricular fibrillation or cardiovascular collapse, and patient is unresponsive to the treatment, quick shock and treatment, then it should be converted to the cardiopulmonary bypass. These are the different positions. While grafting, you can see the stabilizers have been placed and the grafting is being performed. The different hemodynamic changes which can happen during the off-pump CABG, it can be because of myocardial ischemia itself, or because of the stabilization of the required a different position. We are twisting the heart or we are elevating the heart. So all these leads to a compression of the RV free wall, or there is a verticalization of the heart, so the atria has to work more to pump the blood to the ventricle, or there is a distortion of the mitral or tricuspid wall. All these leads to hemodynamic variation. So how do we manage? We give the treatment position. We use the fluid if needed, or vasopressors or inotropic drug. And if not responding, we can always evaluate with the help of transesophageal echocardiography or pulmonary artery or other modalities. So how do we maintain the hemodynamics? Our team approach is must, especially in the off-pump CABG, a good communication between the surgeon and anesthesiologist. We try to maintain the normothermia, and we always bring the pressure up while the surgeon is manipulating the heart. And a sequence of grafting is important, at which vessel has to be grafted first. And ischemic conditioning by lifting the heart, releasing it, and lifting again is helpful when the patient is hemodynamically unstable. There are certain situations where we need to convert to the cardiopulmonary bypass. When the patient is having a cardiac index less than 1.5 for a prolonged time, or there is a decrease in the mean arterial pressure and is not improving in spite of the adequate vasopressors, or there is a persistent ST elevation for more than 2 millivolt, or there is a sustained malignant arrhythmia, so immediately we should switch over to the cardiopulmonary bypass. Perioperative MI, which can be assessed with the help of ECG or the regional wall motion abnormality of transesophageal echocardiography. How we can avoid? We should maintain a blood pressure of above mean arterial pressure above 70. We should reduce the myocardial oxygen consumption, and we should avoid any significant bradycardia. So a pacing is important to maintain the cardiac output. And whenever the ischemia is happening during the distal anastomosis, coronary shunt can be used to avoid the ischemia during the grafting period. These patients can be planned for early extubation if they are hemodynamically stable and they have the normothermia. So low risk patient can be easily extubated when on table, but it should be planned and discussed before the surgery itself. So the patient has been primed, you are ready, and surgeons is also aware that you are planning to extubate these patients. But a careful control of the blood pressure is important, because if the blood pressure will shoot up, there is always a risk of bleeding after the extubation. So whenever we are planning for early extubation, we should look for the body temperature, we should look at the arterial pH, patient should be hemodynamically stable with a cardiac index more than 2, with a respiratory rate should be 10 to 12, above 12 and less than 25, patient is having adequate PaO2, and X-ray should not have any major abnormality. Patient should have adequate urine output. Patient should be awake, cooperative, and moving all extremities. And there should not be significant drainage to the mediastinal or chest tubes. So, how we should manage this? A preoperative education. Anesthetic technique should be tailored for the early extubation with the use of the short-acting drugs. There should be the nurse and respiratory therapist driven protocol, early extubation for a stable patient. Patient should be early mobilized so that we can remove the catheters, tubes, and other devices quickly. Early ICU discharge and hospital discharge if the patient is meeting with the criteria. Post-operative pain relief, it is very, very important with the use of various IV, opioids, NSAIDs, patient-controlled analgesia with the intercostal nerve block, thoracic epidural anesthesia, intrathecal opioids are with the help of intrapleural local anesthesia. What is important that we use the multimodal analgesia to achieve the adequate pain relief so that we can minimize the side effect of the each drug. So to conclude, a thorough clinical evaluation, including the primary disease, cardiac status of the patient, and comorbid condition should be done for the risk stratification, and the risk should be explained to the patient and their relatives. A close communication amongst the team for the plan of surgery, whether we are doing off pump or on pump, but what should the sequence of grafting, what are the expected complications in the perioperative. Adequate pre-medication so that patient is not anxious on the table, and all the cardiac medication should be given except ACE inhibitors. The plan of anesthetic management should be tailored as per the cardiac function as well as what is our plan for the post-operative recovery. Always remember the anticoagulation, the use of heparin, and appropriate planning and communication is key to success, especially in cases of off-pump, because there's a lot of hemodynamic variation while they are twisting the heart or lifting the heart. A judicious use of anesthetic induction agent and technique to optimize the hemodynamics and cardiac function throughout the induction of anesthesia, and fast-track management should be discussed in the perioperative period, and a good pain relief with the use of multimodal analgesia so that we can achieve a fast-track recovery. Thank you very much. I'll be happy if you have any question to ask.
Sir, as of now, there are no questions in the chat box.
Thank you, Dr. Vivek Gupta and Dr. Virmani, for such an excellent deliberations on two very important topics which are of practical importance pertaining to congenital heart disease as well as CABG. And I must compliment both the speakers for an excellent deliberation on these topics. And just one question, is there any first questions in the chat box? We'll pick up that first.
No, sir, as of now, there are no questions in the chat box.
I think that both the speakers were so superb that they made the things very, very clear and lucid to all. Dr. Virmani, just for the postgraduates, the most common congenital anomalies we face nowadays is VSD or pathology of palate coming for brain abscess, and PDA and ASD if they come for emergency surgery. So what will you advise your postgraduates how to go ahead about that? I hope Dr. Virmani is here.
So ma'am is not there. She had some OT thing lecture going on, so she has left. Okay, so over to Dr. Vivek, an excellent talk on off-pump and on-pump CABG. Just take home, you have very lucidly told about the take-home points for the postgraduates. We all understand that nowadays majority of the surgeries are done off-pump, and fast-tracking is the key to it. Any particular inputs about highlighting the role of regional anesthesia in such surgeries?
Yes, sir.
Dr. Vivek.
Yeah, thank you, sir. Thanks a lot, and nice question that role of regional analgesia. It is important, sir, for the early recovery of these patients, and we do put, if not contraindicated, we do routinely put thoracic epidural in these patients, and that gives an excellent recovery in the post-operative period, and even in the intraoperative period, we are able to reduce the anesthetic doses of the anesthetic drugs. So we can expect a faster recovery in these patients. But one should be very thorough for during assessment that there is no contraindication, patient cooperation is must. One thing we should remember, we should not try a multiple attempts for thoracic epidural. If it is, you are not able to put on first or second attempt, it's better to leave because you are going to hypernize your patient. So there is though very less risk of hematoma, but there is always a risk of hematoma because you are going to hypernize. 10 years back, we used to put 1 day prior, but now we have learned more and we are putting on the day of surgery itself thoracic epidural.
But clinically, suppose the bloody tap occurs, and we are doing it on the day
Then
of
we
the
have
surgery.
to. Then we have to. This is why I'm saying we should not. We should always make sure that we are not doing a multiple attempts. Yes, sir.
And if it is a bloody tap, then
yeah,
for the
surgery has
postgraduates,
to be deferred. Yeah, it has to be postponed for
yes,
at least 24 hours.
Yeah, so that's a beautiful role of regional analgesia, but still we have to be cautious. Thank you, Dr. Vivek, for such a nice. I think some question has come up in the panel.
Yes, sir. There are questions in the chat box.
So can you help me in reading those?
Yes, sir. So where heparin is administered in the what dose? When heparin is administered and at what dose?
Great, good question. If we talk about the CABGs, if it is the off-pump CABG, our target is to keep the ACT around 300. So we give a initial dose of 2 milligram. It all depends on what kind of a conduit surgeon is taking. If the surgeon is taking out both internal mammary artery, then they give a half dose when they are cutting the internal mammary artery, the distal end of the internal mammary artery, half dose, and second half dose when they have completed the bilateral internal mammary artery. Right? If surgeon is taking only a single conduit of internal mammary artery, so when they are cutting the internal mammary artery, at that time only we give the full dose, that's around 2 mg per kg of body weight, and with the targeting the ACT of around 300. But if it is the on-pump surgery, the target remains above 400 for all patients, as we do for any other on-pump surgery. So we give a dose of around 3 milligram per kilogram of body weight, and we look at the ACT, and if it is less than 400, then we always, before going on bypass, we give another dose, and then we check the ACT. Never allowed to go on bypass before the ACT has reached to a 400.
Sir, any extra consideration in robotic CABG?
Personally, I do not have much experience of robotic CABGs, but related with the heparin, dose remains the same that as we do for the off-pump CABG.
Thank you, sir. There are no other questions as of now. Thank you, Dr.
Thank
Vivek.
you, Dr. Vivek.
Thank you,
Dr. Vivek and Dr. Vimani. And it was a pleasure interacting with all of you at APPEC2023. Thank you, the organizers. Over to you.
Thank you very much.
Thank you, Naveen, sir, for being with us. Now we will have the MCQs quiz 1, which is a set of 2 MCQs, and you have to give the answer. The first MCQ is, the main advantage of off-pump CABG includes all except less risk of SIRS, grafting is easier, fast-track extubation, and less risk of renal dysfunction. The second question. The second question is, of the following, which line would be considered a central line? An 18 gauge in a patient's external jugular vein, a PICC line in patient's right upper arm, a midline IV in the patient's left upper arm, and a 16 gauge in the patient's left brachial vein. Thank you, everyone. Now we'll have a short tea break and then proceed within 5 minutes.
Welcome back after a quick tea break. Let's move on to the next session, which is a long case presentation of a 48-year-old female patient with hypertension posted for modified radical mastectomy.